Get started. And I want to welcome everybody to tonight's event. My name is Don Lang. I'm the director of Sunnybrook's Board of Directors. I'd like to welcome all of you here this evening. Tonight's topic on concussions, traumatic brain injury, and one that can affect anyone. It can happen very quickly playing sports. Actually, that's where I had mine when I was younger. Falling down, hitting your head, suffering a stroke, or being in a car collision. These are just a few of some of the examples. But the reality is that brain injuries, including concussions, are a significant cause of death and disability for Canadians. Statistics on the Brain Injury Society of Toronto's website indicate that over 500,000 people living in Ontario alone had some type of brain injury, with 45,000 more people being added every year. In just a few minutes, you'll hear from three top Sunnybrook experts providing different perspectives, including assessment, treatment, recovery, and prevention. We hope you will come away with a better understanding and tips to enhance your own well-being. If you haven't already, please consider signing up to the speaker series. The mailing list, you can do so, or you can also find online or on evaluation forms placed on your chairs when you came in. You can also check our Sunnybrook website for details on all the dates and topics and speakers for 2019. And we have many in the works for you hope you can be part of those talks as well. So to get tonight's event started, I'd like to now introduce our moderator, Ari Zaretsky. Dr. Zaretsky is a psychiatrist-in-chief and vice president of education here at Sunnybrook. He's also a professor of the Faculty of Medicine at the University of Toronto. And from 2005 to 2012, Dr. Zaretsky was the director of postgraduate medical education for the Department of Psychiatry at the U of T, and one of the largest psychiatry residency programs in the world. He has won national and international awards in the education for his work as an educator, as a teacher, and as a mentor. Dr. Zaretsky is a founding fellow of the Academy Cognitive Therapy in the U.S. and has a national reputation as a teacher in cognitive behavior therapy, or CBT. His current areas of research and scholarship include CBT for bipolar disorder, CBT training and supervision, and postgraduate medical education. Dr. Zaretsky has been a big supporter of our speaker series, so you may have seen him in the past or heard him speak before. So with that, I'd like to please join me in welcoming Dr. Zaretsky to get all of the talks started. Thank you.
Thanks, Don. So thanks everyone for coming out tonight and joining us for this evening here at Sunnybrook at this special speaker series. I think you're going to learn a lot, and we're going to get started. So first thing is we're webcasting. And so those of you that are watching remotely, hello. Our lecture is called Concussions and Traumatic Brain Injury Facts, Fiction and Fundamentals for Prevention and Recovery. And as Don mentioned, we really have some of the experts in the field who happen to be at Sunnybrook who will be able to elucidate some of the issues and also answer some of your questions. Now, there's a lot of important information to cover this evening, and we will be able to do that through a few housekeeping tips. So first of all, we set aside some time at the end of the evening for you to be able to ask questions to the panel. And in order to do that, we've actually placed some small blank white cards on each chair. Do you have those? Can you show them to me? Good, okay. So,
treated by the surgical team, the trauma unit, and they got sent to rehabilitation hospitals for their follow-up care. But the model of care for patients with mild traumatic brain injury was, well, you'd come into hospital, you have assessment, and then basically you were left to your own devices. And it's very much like that still when you go out into the community. It's not routine that someone who has had a head injury who comes to the emergency room gets a routine follow-up appointment. And this is what the TBI clinic at Sunnybrook is all about. So I think I'm up and running now, but thank you. So this is to give you a nice photograph, an aerial view of Sunnybrook on a time of the day, but the point is that This is a very large trauma center, one of the largest in the country. There is an enormous volume of trauma patients coming through the emergency department. We are not a rehabilitation hospital, but we do have sister rehabilitation hospitals like St. John's. That's a very important point to remember, because our clinic, our TBI clinic in Sunnybrook, is a relatively acute care clinic. As I said, it was established in 1998. It's multidisciplinary. It's not just a medical model. It has occupational therapy and physiatry and rehabilitation medicine. The idea behind it is to give every patient with a mild to moderate traumatic brain injury a routine follow-up appointment. And to stress, this is a very unique model of TBI care. You don't get this in other hospitals. And we particularly want to see people within 3 months of injury. So we want to see people early on, because we think we can make a difference if we get involved early in the course of recovery from a head injury. We have a standardized assessment, which I'll show you, which means that every time a patient comes in, they do the same kind of tests, which allows us to build up a very substantial database, which I'll explain it to you. We get consent from our patients. All the clinical information that we use, in theory, can be used for research purposes. And I would say that 98, 99% of our patients give this permission to use their data anonymously for research purposes. As I said, the data can be used for evidence-based care because we're collecting a lot of information. In 2011, we added a brain imaging component to our clinic, so if people need an MRI, fairly routinely we can get an MRI, although we have to wait a little bit for that. We also started to introduce cognitive testing, but computer-based cognitive testing. Without belaboring the point, because the numbers of patients are so high, our neuropsychology service at Sunnybrook cannot cope with the volume of referrals for people who need their memory assessment or an assessment of their attention. So we started to use some computers to help us do a triage or a screening for cognitive difficulties. We also have a clinic now for adolescents, for people under 18 years of age, and if somebody has a head injury after 65 years of age, I have colleagues in geriatric medicine who are able to help us. So let me just define what a mild head injury is for you. This is the medical definition. And you'll see something they call the Glasgow Coma Scale score, named after a city in Scotland. And the Glasgow Coma Scale score is a numeric rating that we can give to a patient who's had a head injury that very quickly gives us the severity of that injury. And it's a range that goes from 3. 3 is the worst possible score, to 15, which is the best score. And it's a very easy kind of measurement to get. It's based on 3 parameters. When someone's assessed, are you talking? Are you making sense? What's your verbal response? They can be rated. We have a look to see whether their eyes are open spontaneously or their eyes are shut. Would they open their eyes in response to pain, for example? And then we have a look at their movement. Are they moving all their limbs spontaneously or are they not moving limbs, etc. So you get a very simple rating based on these 3 parameters. And as I say, the best possible score is 15. The worst possible score is 3. Anybody who has a score of 13 or 14 or 15, by definition, has a mild head injury. That's one parameter. The next one over there is loss of consciousness. If you lose consciousness for less than 20 to 30 minutes, it's by definition a mild head injury. And the third clinical variable, which is important, is something that we call post-traumatic amnesia. So if you've had an injury and you're unconscious, you don't remember that. But at some point after your injury, your memory starts returning. And depending on how quickly your memory starts coming back after the trauma, that can help us gauge the severity of your injury. And that's called your post-traumatic amnesia. At what point following regaining consciousness does your memory come back on a consistent basis? And if your memory comes back on a consistent basis within 24 hours, that's a mild injury. So I want you to remember 3 things over here. You've got a Glasgow Coma Scale score of 13 or greater, it's mild. If you've lost consciousness for 20 or 30 minutes or less, it's mild. And if your memory starts coming back within 24 hours after injury, it's a mild injury as well. Okay, so those are very important clinical variables for us. My PowerPoint has gone on the blink again. We're a high technology out here, but we're having difficulty with PowerPoint. Thank you. There are a couple other clinical points over here. You just need ISIS 4, 5, and 6. What about someone who kind of, you heard the term, they've had their bell rung, you kind of bumped your head, and you don't lose consciousness, but you're a little discombobulated, you're a little bit out of it for a while. Well, the American Academy of Neurorehabilitation says that's sufficient to say you've had a bit of a concussion. That falls at the very mildest end of the spectrum. That can also be signs of potential cerebral trauma. What happens if you have a focal neurological deficit? So you've had an injury, and for a period you might have some weakness in one of your limbs. Then it recovers, it's transient. That can also be a sign of a head injury. But the big three factors that we focus on are the Glasgow Coma Scale score, the duration of loss of consciousness, and when does your memory come back after an accident. So you've heard a little bit about how common this particular problem is. Now these are old figures, but they're certainly very relevant. That in 1996, they say about 12 to 13,000 people in this province had a head injury. It's almost surely a gross underestimate. During another important point, 84% of these people are deemed mild. The majority of head injury is mild. During that same period, about 700,000 people in this province had injuries. There were over 68,000 road traffic accidents. Not every road traffic accident is associated with a traumatic brain injury. But you can see there's a certain discrepancy between 68,000 road traffic accidents and maybe 12 to 13,000 people with head injury. The bottom line is a lot of people with head injury are being missed. The diagnosis is being missed. If you look at the healthcare costs, you can see that they are considerable. There are two kinds of costs that we get with a head injury. There's the direct costs. So what does it cost the medical system when someone comes into Sunnybrook and they get their care, they see the doctor, they have some imaging, etc., etc. Those are the direct costs. And then there are the indirect costs of things like, well, you don't go back to work, or you're no longer a productive member of society. And you can see from the numbers over here that these are enormous. So the direct costs following a head injury estimated at $125 million. The indirect costs significantly higher than that, well over $400 million. Now here's the important point with mild head injury. People don't die from mild head injury. There is no mortality. So the costs that you're going to get largely with this kind of problem are indirect. The inability to go back to work, the inability to resume being a productive member of society. And when you have a look at head injury, the majority of people that get head injuries are young people, the productive members of society in terms of working, having jobs. And so when these people do not go back to work, the cost to society can be enormous. Yes, just to show you the other side of the coin, this is the definition of severe traumatic brain injury. I'm just going to touch on this very briefly. I've defined what the mild injury is. A severe injury is someone who has a Glasgow Coma Scale score of less than 9, and their memory, their post-traumatic amnesia, the memory only starts coming back on a consistent basis 1 week after the trauma. That's a severe injury. The numbers of patients with severe traumatic brain injury are falling because of good healthcare education. People are now wearing seatbelts. They are more conscious of road safety. And so the severe numbers of TBI are falling. The other thing about severe traumatic brain injury, if someone comes into Sunnybrook with a severe head injury and they're treated by our trauma service, they usually go to a rehabilitation facility afterwards. So they get a good, seamless continuation of care. Hasn't always been the same for mild injury. So what happens when someone comes into our clinic? You're going to be hearing from Elke McLennan, our TBI coordinator, later. She's an occupational therapist. She gathers some really important information like demographics and the kind of data that I described to you, that's the Coma Scale score, the duration of post-traumatic amnesia, etc. There then comes to me as a psychiatrist, as a neuropsychiatrist, that focus on mood and anxiety and memory and attention and concentration. If they have physical problems, if they've hurt their muscles, they can see a colleague of mine in physiatry or physical rehabilitation, the trouble with headache, they see a physiatrist. So it truly is a multidisciplinary model. Patients fill out questionnaires. This is our evidence-based approach. They get an iPad when they arrive at our clinic. Everything is on the iPad. All the questionnaires on the iPad. And all the data is very quickly downloaded into my computer. So by the time the patient enters my office, I have all this data in front of me. And I can follow their scores in terms of depression, anxiety, post-concussion symptoms, etc. It's a very nice model of getting a lot of data quickly. We do the follow-up visits exactly the same model. They come in again, they get the iPads, they fill out the same questionnaire. So we get good, longitudinal data, the second visit, the third visit, and the fourth visit. On average, patients will see us 3 or 4 times. We can follow people for up to a year, and then we have to move care back into the community because, to repeat what I said earlier, we are not a rehabilitation service, we're an acute care hospital. We have to service a very busy emergency room and the flow of patients coming into our ER. Right, so this is an analysis to show you what we've seen. This is an analysis of the first 2,000 patients who've come through our clinic. And you can see the first important demographic, the majority of people with head injury are males. Okay? Men take more risks than women in general. You have a different biology. And the people who take the greatest risk are young males. So the average age you will see, for me, 34 is quite young, but there's a standard deviation. It's quite a good split, you can see. You see the number 13.4 means that our patients generally run between 20 and 40 years of age. That's the most frequent kind of age group that we see in the adult clinic. Less than 50% are married because they're relatively young. And you can see a really interesting demographic which is going up, that 1 in 3 patients now have English as a second language. And that's slowly increasing given the changing demographics in our society with a large amount of immigration. How are people injured? Over 50% in road traffic accidents. You can see MVA motor vehicle accident, they're the driver, about 35%. Passengers, about 18%. Recreational vehicles, we see that with snowmobiles, where people go water skiing, etc. They come down from cottage country with injuries. Pedestrian, about 12%. You can see that this is still a relatively safe city because less than 4% of our patients have been assaulted in terms of their head injury. You see sports, industrial, and other. The other at the bottom is in many ways some of the nastiest injuries we see. We see the young guy who goes along to a bar and he has too much to drink and he walks down the stairs and he falls and he's intoxicated and he can't put his hands out to break his fall and he falls on his head and you see very nasty injuries that way. What's interesting about these data is that if you have a traumatic brain injury that you acquire in a motor vehicle accident, more than 50% over here, you are open to getting accident-related benefit that can help you with your rehabilitation. So that helps fund the aftercare. You can just see what the TBI demographics of the data are like over here. You can see a Glasgow-Coma scale score. Now that you know what the scale is, you can see that the average score is 13, so the majority of our patients have mild injuries. You can see the loss of consciousness, less than 20 minutes, very brief loss of consciousness in a lot of people. Have a look at the duration of post-traumatic amnesia when their memory starts coming back. The biggest group by far, less than 1 hour. This is not a very bad injury, but it's still nevertheless a head injury. If you go all the way down to the bottom, you can see about 27% of our patients are too sedated for us to work out when their memory starts coming back. Why is that? Because people who have a head injury don't only just have a head injury. Some of them have orthopedic injuries, they have a lot of pain, they come into the emergency room, they might have to go to theatre for surgery, they get sedated. Have a look at the CAT scan data over there. 1 in 3 people do not get a CAT scan when they come into our emergency room because the ER physician feels that the injury is so mild, it doesn't warrant a CAT scan. And I'll talk a bit about this just now. In about 50% of patients, the brain scan is normal, and in about 25% or a bit less, they have an abnormal brain scan. What's an abnormal brain scan? You will see signs of bleeding on a brain scan, which is obviously not a good sign. You can see over there that about 20% of our patients have had a previous head injury. This is not their first head injury. About 1 in 3 patients coming with a past psychiatric history. They've already seen a psychiatrist before, which is a very important clinical observation that I'll explain a little later. And then you can have a look at about 20% of risky drinking, about 14% with cannabis, hard drug use is thankfully not that common. About 10% of our patients have had a run-in with the law. They have had some kind of criminal history. So, what do all these data tell us? I want to try and answer 2 questions for you. Well, should every patient who comes through our emergency room have a CAT scan? That's a very important question. And you may say yes, but the answer is that CAT scans come with radiation, and if you don't need one, why get one? So you can see over here that about 30% never got a CAT scan. The ER physician said no CAT scan. Well, the others who got it, about 50% had a normal scan, and about 20% had an abnormal scan. They had some evidence of bleeding in their brain. Did the ER physicians make the right choice? Well, our clinic data can give us some clues as to what the answer is. Here we have a look at three groups. You can see over there, three columns. Over here, you can see these are the groups who never had a scan. This is a normal scan, and that's that normal scan. It's the bleeding. Have a look at the group that has an abnormal scan. The Glasgow Coma scale, a marker of injury severity, is much lower than the other two. In fact, it's less than 13. This is a group that, by definition, doesn't really have a mild injury. It's a moderate severe injury. Have a look at the duration of loss of amnesia over here, post-traumatic amnesia. The biggest group over here are those who've had loss of memory for more than 24 hours after the accident. This is not a mild injury. So you can see from these bits of data over here that our ER physicians are making the right choice. That the individuals with the more severe kind of head injury are the ones who are getting the CAT scan. Good. But now we see something which is really intriguing, and this is not unique to our clinic. You see this in traumatic brain injury clinics wherever you go. Here we have the group that got no scan. Here we've got the group whose scan was normal. Here we've got the group whose scan was positive. And here we have a look at anxiety. And you would think that you're going to get the most anxiety in the people with the more severe injuries, those with abnormal scans. That's not the case. You see a higher anxiety score in this group over here, the group that never got the scan. Why is that? That's a paradox over there. And this is a very important clinical observation because it determines clinical care. We see this again when they come at their second visit. This is not some kind of statistical artifact. When people come back to see us, and about an average 174 days after the injury, about 6 months later, you can see that the group with the mildest injury has the highest anxiety scores. They have the most concussive symptoms. This is the group that's not doing that well. And when they come back to see us at 9 months following the injury, we see exactly the same thing. We see this persistent anxiety and lots of concussive difficulties in the group that has the mildest injury. Why is that? Is that because the individuals who have the mildest injury have the most insight into their condition? Perhaps. But we also know that if you come with a history of anxiety or depression, you are more at risk for developing this following a head injury. Plus, it may reflect greater psychosocial difficulties that these people are dealing with. And so the last bit of information that I want to help you understand why our clinic I think is so important is this. We've established a model here at Sunnybrook in which you offer care to every person who has a mild to moderate traumatic brain injury. You don't get this in other hospitals. But is this working? Is this fulfilling some kind of useful clinical function? So we try to answer this. This was a study funded by the Physician Services Incorporated. We had a look at 191 consecutive referrals, people to our clinic, and we randomized them into those who got treatment and those who got no treatment. Patients were younger than 60 years, no medical illnesses, and we looked at their outcomes 6 months after their injury. No treatment implied doing nothing. The patients came in, they were seen in the emergency room, they went home, we contacted them and said, we'd like to phone you in 6 months' time to see how you do. They could organize their own treatment. The other group, we saw them within 1 week of injury, and we started to structure a treatment program for them. They came in with a partner, with a spouse, we gave them education about head injury, we gave them follow-up visits according to their clinical needs, they saw specialists, they saw physiatrists for their physical difficulties, they saw me for their behavioral problems, they went for physiotherapy, they were treatment for their dizziness if it was present, they saw an occupational therapist, really comprehensive multidisciplinary treatment. And here's the result. There was no difference between the two groups. Why? The majority of people with mild injury generally get better by themselves. But there's a group that doesn't. There's a 10 to 15% who remains persistently symptomatic. So let's look at that. What about patients who are at greater risk? What about those who are more vulnerable? And we focused on two groups. People who've had a previous head injury and those who come with a past psychiatric history. Well, 30% of our patients had had a previous head injury. Our clinic didn't make much of a difference to that. When it came to past psychiatric history, about 1 in 5 people came to us with a history of some kind of mental health difficulty before their head injury. And it was here that we saw the greatest benefit. When we followed this group over time, they were less depressed, they had less behavioral problems, they were doing much better from a mood perspective, and the level of function was higher. So, if routine treatment reduces rates of depression in those at risk, might this also benefit their cognition? Might there be improvement with respect to their memory and their retention and their problem solving and their speed of information processing? So we looked at that. Because there's a little bit of data from an old study going all the way back to 2001 that suggests if someone with a head injury is depressed, when you treat their depression, they may show some improvements with their memory. And in fact, we showed this as well. And so by treating someone's depression and their anxiety and their mental health difficulties, you have the added knock-on benefit of helping them with their memory and their attention and their concentration. So, our TBI database, we've got good longitudinal data to use for research. We welcome collaboration. We need to find funding to sustain this. But I'm out of time. And we take you back to this really nice view of Sunnybrook, with a couple of data, so a unique approach to the management of head injury. We focus on those who continue to not get treatment, and we would like to think, at least for a good subset of our patients, we're making a difference. Thank you for your attention.
Thank you very much, Dr. Feinstein. If you have any questions, please write them down and hold up your hand so one of our volunteers can come by and get your questions, which we'll bring to the front. We'll take some time right now if you can write down your questions. I'd like to now introduce our next speaker. LP McClellan is an occupational therapist here at Sunnybrook and also the clinic coordinator in the Traumatic Brain Injury Clinic at Sunnybrook, working together with Dr. Feinstein. This clinic provides leading care through an interdisciplinary team, including assessment and management of the physical, emotional, behavioral, cognitive, psychological, and psychiatric symptoms following mild to moderate traumatic brain injury. LP was instrumental in the development of a recovery care guide for patients with traumatic brain injury. And actually, if you Google mild traumatic brain injury right now, you're likely to find it as one of the major hits on Google. Please help me in welcoming Elke to the podium this evening to discuss tips for concussion recovery and successful return to activity.
Hello, everyone, and thank you for the introduction. Before I begin, what I wanted to do was just poll the audience and see who's had a concussion before. If anybody has ever had a concussion or knows someone that's had a concussion, hands up. And I'm going to put my hand up as well. So quite a few people if you look around. So you know that concussions are happening. And what I'm going to do today is talk a little bit about concussion. I want to go over some points about what is a concussion, what are the symptoms of concussion. I want to go over some of the key messages around recovery from concussion. I want you to get a better sense of some of the evidence that's out there. We have some really good evidence on concussion out there, and I want you to get a sense of that. And leave you with some tips and tools and strategies that you or someone you know can use if you are dealing with a concussion. And finally, share some resources and contacts with you. So we'll dive in. I think the first point I want to make, and as Dr. Feinstein was saying, that a concussion is an injury to the brain. And that's a pretty key message, I think. Our brains are the most important part of our body. They control everything, right? Everything we do, everything we feel, how we act, how we behave. So when we have an injury to the brain, we really need to respect that. There's a lot of unanswered questions still about concussion. And what I wanted to do is just tell you a little bit about what the evidence tells us in terms of what is a concussion, the mechanism of the injury. So we all have skulls, and inside the skull, we have our brains, right? And our brain is kind of sort of like a jelly-like substance, right? When we're walking around or for, jumping, or even if we kind of bump our head on the cupboard, our brains are well protected by our skulls and by the fluid that surrounds the brain. But if you have a really strong impact to the head, so a direct blow to the head, it can also happen if you hit your neck or the upper part of your body really hard. It can cause a lot of movement of the brain, and that brain can kind of shake around in the skull, kind of jiggle and wiggle, and it can move quite rapidly. And what happens is it leads to some stretching and shearing at a very microscopic level, and can also cause some chemical changes in the brain. And it's these chemical changes that alter the brain function, and it's very temporary. But what it does do is it results in some clinical signs and symptoms. So I just want to show you this slide and let you know that when people have a concussion, they can present with a wide range of symptoms. Some people have one, some people have more than one, but generally we break down the symptoms into 4 main categories. And when you think of a concussion, most people think about the physical impact, right? The symptoms you can get. So people can get headaches and dizziness, light sensitivity. Those are really common ones. But also, as Dr. Feinstein was saying, people can have cognitive symptoms as well. So people can have trouble concentrating and focusing and paying attention. Another big part of the story, as Dr. Feinstein was saying, was this emotional symptoms. And sometimes the symptoms are caused by the concussion themselves, but as Dr. Feinstein was saying, many times what we see in our clinic is sort of that secondary impact. The fact that, some people aren't recovering as fast as others, and that can kind of get depressing for some people. They can become anxious about their symptoms. And sleep, that is also a big area that is affected after concussion. So people can have trouble falling asleep and staying asleep, waking up early. What's important to know is that some of these symptoms can be affected by others. So for example, if you have a headache that has persisted for a long time and that isn't going away, it can get pretty depressing, right? And you can have trouble sleeping, and then when you don't sleep well, you can be irritable, and when you're irritable, you can have trouble concentrating and whatnot. So, everything's kind of all jumbled together sometimes. And the other important point to note is that other symptoms and conditions can mimic the symptoms of concussion, right? So if you have, let's say, a whiplash injury, and whiplash can cause headaches, but these headaches can also mimic a post-concussion headache. So it can kind of make the recovery and the plan a little bit more challenging. So I think another important really message is that if you suspect that you've had a concussion, you really need to get it checked out by the doctor and get a proper diagnosis so that the proper treatment can be offered to you. In terms of recovery, as Dr. Feinstein was saying, most people do recover from a concussion, and they recover within a few days and weeks and get back to their normal life. The expected timeframes for recovery, according to the current research and evidence that's out there, is that 10 to 14 days, adults will recover. Most adults, and children and youth, they take a little bit longer. So the evidence is saying that about 4 weeks for children. But there is that population where their symptoms just linger and the recovery is a little bit more delayed. And that figure for adults is about 15 to 20% now is what the literature is saying. And with children, it is even a little bit more. I think they're saying about 30%. So the focus of today's talk is more on the adult recovery from concussion. I'll be referring to children a little bit, but it's mostly to do with adults. As Dr. Feinstein was saying, there are factors that can influence recovery. We know that older people and children, they take longer to recover. And as Dr. Feinstein was saying, that there are comorbidities that also influence recovery. So if you have a pre-existing mood disorder, learning disorder, ADHD, we know that that can also influence your recovery. Another important point is that if you've had a prior concussion, right, so if you've had more than one concussion, and especially if you've had a recent concussion, and then you have another concussion, that can also delay your recovery. So that's important to know. So that brings me now to the next slide, and we're going to talk a little bit about recovery and what do you do to get better, right? So what we do as clinicians and what I do in the clinic is I really want to make sure that patients understand their injury, right, what happened to them, and what they can expect from their recovery. But there are also things that, we want to tell our patients in terms of what they can do to get better, because the answers are not all medical, right? You can treat headaches with pain relievers, and you can get treatment, as Dr. Feinstein was saying, but there are things that we can do to help manage our own recovery, and that's going to be the focus of my talk. So the evidence is always evolving, right? And we know that the brain is injured, right? And when you have an injury, you need to rest, right? So we know that with concussion, you have to rest, but a concussion is like a hidden injury, right? You can't see it. You can't see the brain. And as Dr. Feinstein was saying, it usually doesn't show up on imaging. So it can be a little bit more challenging for people to understand what they need to do to get better. It's not like a broken arm or a broken leg. You can put it in a cast, and, basically the cast forces you not to use it. And when the cast comes off, you get some treatment. You can do some exercise and you're good to go. It's not always that simple with concussion. So rest is important. Like any injury, the brain needs rest. But the challenge has also always been how much rest, right? So again, the evidence is changing constantly. And for a long time, what we used to tell people was go in a dark room, turn the lights off, no sound, and stay there until your symptoms went away, right? And what happened was, you can imagine, some people, they just stayed there, right? Because their symptoms didn't go away. And the evidence is saying that prolonged rest actually can do more harm than good. And if you think about it, if I put any of you in a dark room, whether you have a concussion or not, you get pretty antsy, wouldn't you? And be socially isolated, probably get totally depressed, and you'd be worried about missing work or school or whatever obligations you've had, and it just make you more anxious. And anyway, the evidence now is saying that no more prolonged bed rest, okay? The evidence is saying that we need to become active, and we know activity is good, it's a good thing, but the challenge is always knowing how much activity is good, right? So we have to find the right balance, because too much activity is also not a good thing. And we're going to be talking about that a little bit in my talk. So how do we know what the right approach is to activity? How do we know what's too much and what's too little? So here's where we turn to the guidelines. So in terms of mild traumatic brain injury concussion, we do have evidence-based guidelines, and I just want to draw everybody's attention to the Ontario Neurotrauma Foundation. These guidelines have been around a long time, and it's actually in their 3rd edition now, which just got released in June 2018. So I want everyone to take note of that, and it is a really good resource. And what's really exciting is just recently they have released a patient and family version of the guidelines. So these guidelines tell clinicians and now patients and families as well about how to manage your recovery from concussion. So I think there's on the tables, I put some information out there, and there's actually some booklets as well. And as Dr. Zaretsky was saying, we also have a concussion handbook online, and some of you might have picked up the little bookmarks. We'll draw you to the link on the website, but if you Google Sunnybrook concussion, you're going to come to the handbook there, and it's going to tell you pretty much everything you're going to hear in my talk today. But the guidelines are saying that a brief period of rest is needed. So for adults, 24 to 48 hours of rest is beneficial. And after that, we have to become gradually and progressively more active, as long as it does not result in a significant or prolonged exacerbation of symptoms. So what that means is that as long as your symptoms don't last too long or get too strong. So we need to be becoming more active. So what does this rest mean? That can be confusing, right? Does rest mean staying in bed all day? What does it mean? It actually means getting a good night's sleep and taking naps if you need. And this is in the first 24 to 48 hours. So you've been diagnosed with a concussion, you need to rest. And I kind of relate it to being home with the flu, right? I mean, you're not going to feel great probably. So you're just going to kind of take it easy, do really gentle things. It's okay to, listen to music, get up and eat, little quiet socializing. But the big key is to rest your brain, both cognitively and physically, right? So cognitive activity, we don't want people on their cell phones and texting and watching a lot of TV, being on the computer, busy places. All of these things are just going to cause too much stress on the brain, and the brain needs to settle, relax, and heal. The physical activities also needs to be limited, so we want to be avoiding any sort of strenuous exercise, running around, doing chores, that kind of thing. People are instructed not to drive, again, a very cognitively, visually demanding task, and we want to make sure that the brain is settling, and we want to keep people safe as well, because they may be dealing with some problems with their concentration, they might have a little blurred vision, so we don't want them driving. And basically, we do want people to take it easy and take a day off work or school or other family obligations. But after that, we have to become more active. So how do you do that? And the point of this slide is really just to show you that there is a progression, right? And this slide actually is aimed for kids. So the parachute.org, another very good resource for people, they have all sorts of different strategies and plans and protocols to get people back to activity. But the point of this slide is to show you that there is a progression, and it's a stepwise process. And you do not progress through the stages until you are able to tolerate that stage. So I think everybody in the audience is an adult, and because the focus of the talk is for adults, I wanted to show you how that progression might look for adults. We don't have anything fancy like they do for kids, so this is just kind of something I put together to show you. And the key messages are that everybody's going to progress differently. Everybody's injury is different. Everybody's situation is different. Their jobs are different. Their demands are different. So everybody's going to be different. And you really have to make a plan that works for you. But after that acute stage, you're going to start by doing stuff at home, right? So hopefully, you're taking a few days off work, and gradually you're going to try to become more active. You're going to start introducing more activity in your day. And we usually start, with 5 or 15 minutes of activity, 1 or 2 tasks at a time. We really want to take it easy and not, do everything all at once. And then gradually build up. We want to establish a regular routine in the sleep schedule. And this one's really important because this is not just for people that have just been newly diagnosed. This could be for the people that are, still struggling with persistent symptoms. Some of the people that we might be seeing in our clinic about 3 months later, they're still at this stage, right? So we're going to try to get them out of this stage. And the one thing that I always reinforce is we have to start making a schedule, right? And we're going to prepare for that next stage. So get up at the same time that you would for work, go to bed at the same time you go for work, and get dressed and go out and make plans, and slowly start to practice work-like tasks, and for our students, school tasks as well. So start building your tolerance on the computer, start reading, start getting ready to go back to work. So the next stage, when you can tolerate that activity for longer, we want everybody to ease back into work and school as well. This is really important because we want to gradually ease in, and everything's got to be gradual, right? So when you go back to work, we usually recommend a reduced load and a part-time schedule, and gradually building up. People can benefit from accommodation. So if you are, going back to work with a concussion, speak to your school, speak to your employer. There are plans that can be put in place to help you get back to work. These are called accommodations. So it might be things like, if you're a student, you might get extra time on your tests or exams. If you, maybe work in an office, they might give you some flexibility around the deadlines that you might have, give you some extra time to do tasks, maybe work breaks during the day. This is all really important. We want to gradually, build up those days and basically take it easy and do what you can. And then you're back to full days. So sometimes people, they go back to full-time days, but they might, only work 4 days a week. I know that everybody doesn't have the luxury of doing that, so you really have to figure out a plan that works for you, and make sure that you're speaking with your doctor and your employers around that to get you back to work. And when you can tolerate full days in your regular schedule, then you are ready for being back at work full time. I think a really important message that we have at the bottom here, and you'll see this sort of all over the concussion literature, and I think Randy might even be talking about this a little bit as well, is these high-risk activities. When you're recovering from a concussion, you want to make sure that you avoid activities that are going to give you another concussion, right? So no ladder climbing and no bungee jumping or things like that. You just really want to protect the brain while it's still healing. And again, everybody is going to be different in how they do this. Some people will get through the stages really quickly, and some people may need a little more support, and that's where our clinic can help. I just want to show you the slide again for Parachute Canada. If there are any athletes out there that are planning on going back to exercise or contact sports, again, really a stepwise process, and you need to be doing that safely. And no contact sports, or what we call gameplay, until you have seen a doctor and be fully cleared to do so. So that's really important. So when people come to the clinic, these are the questions that I commonly get. So keep in mind, these are maybe people that are struggling a little bit more in their recovery. But how do I do all that? This all looks great on paper, progressing through these stages, but how do I do that? I can't even do like 5 minutes on the computer and I get a headache and I'm done for the day. That just won't happen. I can't do it. So we're trying to figure out what is that right level of activity. And if you remember the slide before, too much, too little, you have to find the balance, and there's a way to do that. So where I usually start is, I think this is a good analogy and take-home message for you as well. I think it really helps understand what's going on, when you have a concussion. And I like to use a cell phone battery. You might have heard the gas tank analogy, or there's a money in and money out of the bank analogy. But essentially, in this analogy, you think of your brain like a cell phone battery. And the energy that you have is the charge in the battery, right? And if you think of it, everything that we do in our day takes up energy, just like our cell phone applications and so forth. Like, it's all taking up energy. But when you have a brain injury, a lot of the energy is going into healing the brain. So these chemical changes that go on the brain, it's causing this kind of energy crisis, we call it. And a lot of the energy is going into the healing the brain. So the battery is half full, right? And it's really hard to keep it charged. It's never fully charged. So when we're doing things, it's going to drain the battery even more, right? So if we don't get enough sleep or rest, right, we're not going to charge the battery. When we do things, if we do things for too long, or if we do things that take up too much physical or cognitive effort, if we're in busy environments, if anyone's dealing with a concussion now, if you're like a lot of bright lights or noises, or places like Walmart or Laser Quest or something like that, it could be really, really difficult for you. And stress and worry also make the brain work hard. So these are all things that are going to drain the battery. And when the battery's drained, there's not a lot of energy left for healing, right? So I don't know if that makes sense, but we want to make sure that we keep the battery full. And how do we do that? So like I said, good night's sleep. Everybody needs sleep, but especially after concussion, you want to charge that battery, get your good night's sleep, and then limit the tasks that take up the charge, right? So in the next couple of slides, I'll show you how we do that in terms of paying attention to your symptoms and how do we manage those energy wisely. We want to recharge often with strategies, and these are all strategies that that you can do. They're called sort of self-management strategies, and they're outlined in our concussion handbook as well as the Ontario Neuro Trauma Foundation handbook. They've also given you some good strategies around that. We'll go into that in more detail. But essentially, what we want to do is avoid that low battery warning and prevent the shutdown. And many of my patients talk about this, the brain feels like it's shutting down, right? So if they are doing too much, they get exhausted, and then their symptoms start to come on, and then, you know, they can't focus, and then basically they say, you know what, I've shut down, right? So we want to avoid that shutdown. So how do we do that? And this is a graph I like to show. I think it explains nicely that whole concept of doing things within your tolerance, right? So we have 3 zones, the 0 zone, which is where it's your baseline, right? So let's say you have a headache and it's a 2 out of 10 on the pain rating scale. And that's where you kind of start your day with a 2 out of 10. The mild, you know, might be a 5 out of 10, and the significant is like the worst pain, right? That's your 8, 9, 10, when your battery is drained, right? And you are shut down, you can't do anything. So in the first few days, you know, so for people that are early on in the recovery, we do want to keep your activity levels in the green zone. But after that, like the guides tell us, we have to increase our activity level. So we have to kind of challenge ourselves a little bit, right? And know what our tolerances are. And we do that by doing small bursts of activity, interspersed with rest. And it's okay to go into the mild, but very temporarily, right? The mild is really just our warning to say, you know what, whoa, that's a little bit more than I can handle right now. I need to take a break. I need to stop and, you know, do something else. That's too much. So going into the yellow zone is okay. And basically we're teaching people how to pay attention to their symptoms and know sort of what their tolerances are so that we can slowly start to build up and we want to avoid going into the significant zone. You know, activity logs can help. Again, this is in the concussion handbook. It can kind of help you track your symptoms and your activities and what you can and can't do. And then this slide here just shows us what we don't want to do. And what we don't want to do is push through our symptoms, right? We all have busy lives, and it's really easy to do, you know, just 5 more minutes on the computer. I really need to get this done. Or it's, you know, I've got to finish mowing the lawn. It's going to be dark soon, right? So we do not want to push through the symptoms, because what winds up happening is you push, and you get into your, you know, unbearable, like that significant zone, and then you wind up crashing. It's called the bust and boom cycle, because what happens when you crash is that it can take days, weeks to get back to your baseline. So if you keep pushing through and you're doing too much activity, you're going to spend most of your time, your activity levels are going to be mostly in the yellow and the red zone, right? So that's when your symptoms are at their worst, right? So we really have to learn to pay attention to our symptoms and what we can tolerate. And over time, what happens is that you begin to tolerate more, your threshold goes up, and you spend most of your day or your activities in the green zone where you can tolerate your symptoms, right? And then, you know, sometimes you might go in the yellow zone, and again, that's your warning to say, oh, need a break, right? So you really have to listen to your body and pay attention to your symptoms. And again, it's a bit of trial and error, and you know, you gotta work at it, but it does work. And I've had many patients tell me that. So in terms of staying in that green zone or keeping the battery full, there are management strategies that we can all use. These are things that you can do as part of your Get Better plan. You know, again, it doesn't, you know, everybody's going to be individualized, and, you know, there is going to be people that need treatment and might need some medication, but these are things that you can also do to help you get better. So we'll start off with sleep. That's the first place to start, and it's my favorite thing to do. So we know sleep's important, right? And know, if anybody's ever had a couple of nights in a row with poor sleep, it can, really take a toll on you, make you irritable and make it hard to get through the day, as I know very well. But sleep is really important. It's good for, obviously for recovery, but also just for our general well-being, our mood, and our physical well-being as well. So sleep is the first place we start, and it's often, a problem for a lot of our patients. So there are strategies that you can use to help you sleep, and we call that sleep hygiene. And sleep hygiene is not about, going to bed clean with a shower and fresh pajamas. Sleep hygiene are strategies that you can use. So things like keeping that routine. We talked about that a little bit. At the same time, waking up at the same time, going to bed at the same time, trying to limit your naps, and doing that throughout the week, even on the weekends. That's usually the first place that we start. And then another big one, and sometimes easier said than done, is this electronics in the bedroom. Seems like we're all glued to our phones, but the really important message is that you can't put it away 30 minutes before you go to bed, because we know that the blue lights and just the activity of being on your phone and doing things can keep the brain awake, and the brain needs to get back in its sort of sleep-wake cycle. So it needs to know it's time to shut down and go to bed. Other things, just have a comfortable bedroom, avoiding caffeine and heavy meals and alcohol before bed. These are all important strategies, and stress management as well. If stress and worry is keeping you up at night, then that's going to be a problem. So we want to make sure that that's addressed. Again, all these strategies are in the handbook, so if people are interested and they want more information and more detail, you can see that in the handbook. Energy conservation is a big one, especially for occupational therapists. So, we know that they have to keep the battery full and maintain our energy levels. So we do that with a concept called energy conservation. And we think of it as the 4 Ps, and that's a good way to remember it. So we want to make sure that we prioritize our time and our energy, and basically focus our energy on what matters most, right? So if you have an important meeting in the day, or maybe you decided that you wanted to come to the lecture here tonight, you want to make sure that you prioritize that energy and save the energy for the things that are most important to you. And if you can ask other people to help you with some of the less important ones, or maybe defer them or delete them altogether for a while, then it's a wise thing to do. Planning and organizing your day. So this is really important that sort of we think ahead, right? And kind of, again, trying to figure out what tasks take up a lot of energy. Know that, you're going to need more breaks probably, so things are going to take a little bit longer. So keep that in mind. And also, one thing that's really important is that try to do the tasks that need a lot of energy during the times that you have a lot of energy, right? So if you have, an important conversation that you need to make on the phone, or you are maybe going to sit down and do your taxes or something, right? Make sure you're doing that at the time of day when you have the best energy. Using a planner and a to-do list obviously can help, and especially if you are having some trouble with your memory, it always helps to write things down, helps to see it on paper, and it takes the stress away of having to remember. Sometimes the stress itself can, delete or deplete the energy in your battery. Pacing and taking breaks, so important, right? And pacing isn't just about resting and taking a break. Pacing can also mean switching tasks. So if you are having trouble on the computer, for example, and you can do 20 minutes on the computer, and you know that you need, to take a break after 20 minutes, doesn't mean you have to go and do nothing. You can still be productive. What it means is that you don't want to go and maybe text a friend or check your text messages, because you want to sort of switch it up. You want to go from a cognitive task to a doing task, right? So that you're balancing your energy, right? So maybe you can, go from reading to folding the laundry, right? So that's important to keep in mind. And positioning yourself, that's the last P. So changing postures help, right? And especially, if you're on the computer and these laptops, especially, you can get a lot of neck strain just from poor postures and cause headaches. So pay attention to your postures. Use tools to help. Some people benefit, from earplugs or sunglasses. We don't encourage people to wear them all the time if they can get away with not wearing them all the time. But especially, if you're in a noisy place or a bright environment, it can certainly help conserve some of your energy. Some patients have told me that anti-glare and blue light filter screens can be very helpful. It's just an example of another tool that you can use. If, for example, the computer is bothering you, you can get them, at Staples and on Amazon, and a lot of people find them very helpful. Quiet space to focus, again, changing the environment. It can be as simple as that. So if there's a lot of noise around and you're trying to do something at work, see if you can, go to a quiet place if you have to do something that needs a lot of focus and energy. And then lighting can be helpful too. So, if you're at home or at work and the fluorescent lights are bothering you, you can get them switched out, and that can certainly help save some of your energy. So it's about sort of being aware of all the things that, take up energy, and what are you going to do to kind of modify either how you do things or the environment. And those are the things that are going to help you keep that battery full. Nutrition, we'll just touch on that. Everybody needs to eat, but especially after concussion, it's really important that you start your day with a healthy breakfast. The brain is, one of the most metabolically active parts of your body. It needs nutrition, nutrients to function at its best. So we really want to make sure we're eating breakfast, eating those regular balanced meals. And I just put the Canada Food Guide up there because it's always a good resource. A lot of people, kind of don't think about nutrition and concussion, but it's important. Drinking enough water, trying not to have a lot of caffeine, and if you can stay away from drugs and alcohol, it can affect your brain recovery. It can certainly slow it down, but there's also a risk as well, right? So if you are under the influence, like Dr. Feinstein was saying, you could fall downstairs and hurt your brain again, and that wouldn't be a good thing. So we try to, counsel people on at least cutting down on that if possible. And lastly, relaxation, very important. We want to make sure that we take time to relax and we put it in our schedule. There's a lot of good, strong evidence on relaxation and healing from any injury, but just general well-being. So really it's about finding things that you do find relaxing, but making sure they're not symptom-provoking activities, right? So maybe before your concussion, you relax by running. If you haven't gotten to that stage, I suggest you don't run as a relaxer. Try to find something that you enjoy that is relaxing. So just a couple of examples out there. Mindfulness, meditation, that's a big one now, right? So if you look that up, you'll see a lot of apps out there on mindfulness and a lot of groups, and it works, it helps. So it's something to think about. But if it's not your thing, just even taking a moment in your day and enjoying the scenery or just a quiet bath all to yourself, that can be very energizing and relaxing at the same time. And like I said, put it in your calendar, because that seems to be the last thing that people schedule. So this is just a link to our concussion handbook. It's available for anyone to access online. It's free of charge. And you can pick up a bookmark outside with the link. This is the Ontario Neurotrauma Foundation and Concussions Ontario, another very useful resource, very reliable, evidence-based stuff on there. But you can see that is a patient version now of the handbook. It's a good one. And that information handbook, maybe some of you picked up outside, but that's a recent publication from the Concussions Ontario, and it has some really good information on concussion, really simple, easy to follow, but also on how to find good quality concussion care. So there's a lot of concussion clinics out there now, and there's some really good information in that handbook about, what are the right questions to ask and how do I find a good concussion clinic that's going to be working with evidence-based information. And lastly, I don't want to forget about the Hollow View. They're our neighbors just across the ravine here. If anybody has kids or knows of kids under the age of 18, this is your go-to for concussion information. They have this excellent handbook called Concussion in You. Again, it's free to access online. They offer workshops and information sessions for kids and youth and parents of youth with concussion. So I do want to draw your attention to that because the recovery is a little bit different for kids. The concepts are the same, but the messages are just a little bit different. So if you are under 18, make sure you are looking at the guidelines and the resources for children and youth. And just some more resources. I know the Brain Injury Society of Toronto is here. They've got a booth outside, an excellent resource and support for anybody living in the Greater Toronto area. If you're from outside of Toronto, or even general information, the Ontario Brain Injury Association, another excellent resource. And then some of the resources that we talked about earlier in my presentation. So if you want to snap a picture of that, and those are really good, reliable resources for you. And lastly, our take-home messages. So if anything, what I do want you to get out of today's talk are these points. If you or someone is dealing with a concussion, know that it takes time. Everybody's recovery is going to be different, but focus on what you can do, right, and what's most important. I think that's a key message, right? We want to start doing, and so if you think of what you can do and all your accomplishments, and it really helps for you to set goals and move ahead in your recovery. Like we said, don't push through your symptoms to get things done, right? Again, that's going to drain the battery, put you into that danger zone, and you're just going to crash and be down and out for a bit, and it's just not going to speed along your recovery. Listen to your body. That pacing and paying attention and to your symptoms is really crucial to your recovery. And know that returning to normal activities is gradual and stepwise. It requires attention, caution, and patience. And it is kind of like climbing a cliff, I think. You set a goal, you embrace it, but you proceed with caution. Use your techniques and tools that you've been given. Sometimes you're going to push yourself a little bit out of your comfort zone, but at the end, you're going to get there, right? And it's just such a, patients tell me, like, when they come back and they're finally able to, be on the computer for an hour, or they've, gone back to work, it's really exhilarating, right? And I've had a patient say it's kind of like, looking at the horizon when I've climbed a cliff. So that's why I put that picture up there, because I always think of that patient, and she said it a lot more eloquently than me, but I think that's an important message, is that it does take time, and for some people more time. And so don't be disheartened if that's where you're at, and just know that, if you use the strategies and some recovery plans, that it can get better. And again, recovery is different for everyone. So if anybody out there is struggling, make sure you speak to your doctor and your healthcare provider if you need more support or help.
You dropped something.
I know.
It's okay. Okay, so thank you, Elke. For those of you that have questions, please fill them out right now. Put up your hand, and we're gonna have a rapid fire Q&A right after this last presentation by Brandy Tannenbaum. So Brandy is our last presenter, and she is the program coordinator of the Tori Trauma Program in the Center for Injury Prevention. Brandy's work includes developing Canada's first web-enabled injury surveillance platform for community organizations and outreach to internal and external partners around the area of injury prevention. It's very important work, so please welcome Brandy to the podium to talk about prevention strategy.
Everyone, thank you. I'm gonna see about this. Oh, there's that, so perfect. Okay. Thank you, Dr. Wizaretsky, and tonight's organizing committee for providing the opportunity to share information from the Center for Injury Prevention on this important topic. We have heard about the complexity of diagnosis and management after concussion injury, and as you will see from the perspective of prevention, there is also complexity in the efforts to reduce the frequency and severity of concussions. I thought we could start this portion of the presentation with a case study to shed light on some of the key elements in concussion detection, management, and prevention. Rowan Stringer was a vibrant 17-year-old teenager when she died as a result of second impact syndrome while playing a high school rugby game. And this video, the short video, captures the events as they unfolded in the days and weeks leading to her death, and a message from her parents about their wishes for Rowan's legacy.
A 17-year-old Ottawa girl has died after suffering a severe head injury last week during a rugby game. Rowan Stringer was in her second year playing for the high school team. She was also its captain. Friends and family of the grade 12 student are expressing shock and sadness at news of her death. Christy Neese joins us from Ottawa. So Christy, tell us more about what happened.
Well, Rowan was playing a high school rugby game on Wednesday when she was tackled hard and hit the ground. The play was stopped and she was rushed to hospital with a severe head injury. Doctors at the hospital tried to relieve the pressure in her head, but they were unsuccessful. And on Saturday, her family decided to take her off life support. She passed away last night, surrounded by relatives. The CBC spoke to her parents this afternoon. Kathleen and Gordon Stringer say Rowan had been actually hit in the head a week before the fatal injury. She had a headache afterwards and took some pain reliever. Then 2 days before the fatal hit, she was hit in the head again. This time, she told her friends, but she did not tell her parents. Gordon Springer says the family is not looking for anyone to blame. Instead, he hopes his daughter's story can help to educate people. And here he is speaking a little bit more about that.
We're not looking to sort of blame anyone for anything here. It was an accident, it happened. But if there's something that can be learned out of it and perhaps help to take a step to preventing something like this happening again, and we would hope that would be able to implement something.
And her family has decided to donate her organs. Tell us more about that.
Well, Gordon told me that Rowan wanted to be a nurse and to help children in Africa, and so that influenced their decision to donate her organs. The family's been told that her lungs are going to help a 20-year-old woman in Toronto. Her kidneys are going to Sick Kids Hospital, also in Toronto, and her pancreas is headed to that city as well. Her liver will be going to London, Ontario, but her heart will be staying here in Ottawa. Now, at her high school today, grief counselors were helping staff and students deal with the loss. No sports were played at the school today at John McCrae Secondary School, and they've been canceled for tomorrow as well. A memorial service for Rowan has not yet been scheduled. Andrew?
Christy, thank you. The CBC's Christy Neese in Ottawa.
Okay. Well, when we're working on the presentation, I can tell you that 6 years after Rowan's death, the landscape of sport-related concussion has changed substantially. The province of Ontario passed Rowan's Law last year that requires action and education on concussion in high school sport. The effort to support the development of these actions is being led by an advisory committee with Sunnybrook's own Dr. Dan Cass serving as the chair. Thank you. There has been much learned from Rowan's experience and the leadership demonstrated by her parents and community to address the gaps in concussion in the sport environment. And what we learned through this process is transferable to other areas of society where concussions are often as mysterious as they are in sport. We have and continue to learn about the importance of research. While little research had been focused on children and youth prior to 2013, there is now a concerted effort to learn more about the effect of concussion in young people. We're particularly proud to be a small part of the efforts being undertaken by our colleagues at Holland Lordview Concussion Research Center under the leadership of Dr. McReed. We have and continue to learn about the importance of building and sustaining a supportive culture where policy supports reporting and recovery. And the Canadian Injury Prevention Organization that Elke mentioned earlier, Parachute, has been leading efforts to harmonize concussion policies across sport organizations. We continue to learn about the value of data and injury surveillance. And unlike other areas of public health, we know very little about injury statistics. We know very little about concussion in terms of where it happens, when it happens, to whom it happens, and the contributing and causal factors. The Center for Injury Prevention has been working on this platform since 2010 to help organizations track injuries and the information about injuries that can answer some of these important questions. And we have and we continue to learn about the importance of education across all stakeholders. And like with policy, Parachute is promoting one consistent education platform for coaches, teachers, athletes, parents, and medical professionals. I want to share a little bit about the work that we do in injury prevention. And whereas the concept of medical diagnosis and treatment is commonly understood here in the hospital, the concept of injury prevention is not generally well understood. Injury prevention is a practice largely governed by the public health system. It's a population-level practice that uses data and evidence to reduce the frequency and severity of injury caused by chemical, thermal, and mechanical forces. The practice of injury prevention in public health has been around for thousands of years, but has been more formalized since the mid-1800s and the modern era of public health. And we've seen so many successes in the practice of injury prevention by following tested principles and frameworks. Some of these more recent developments will be familiar, like workplace safety, safety equipment, transportation safety devices like seat belts, car seats, booster seats, airbags, lane detection systems, and more. And some will have been long forgotten because their causes were eliminated completely. Like I'm sure nobody here today has heard about the injury called Fosse jaw from the late 1800s, early 1900s. It's been forgotten. Congratulations to public health. The Center for Injury Prevention was established in the trauma program at Sunnybrook in 1986, and it was the first of its kind in Canada. Today, there are other injury prevention programs across the country in many other trauma centers. Our programs are guided by internal statistics as well as community and national level data both in Canada and abroad. And as we've come to learn with advancements in data collection and the study of injury generally, injury is a worldwide epidemic and a leading cause of death and disability in every country on the planet. In Canada alone, it's the leading cause of death and hospitalization among those 45 years of age and younger. And the costs are more than $27 billion each year in direct and indirect healthcare costs. I thought it might be helpful to provide a quick overview of some of the key principles and frameworks that direct what we do and how we do it. So first up, give me 1 second. So this image here, this diagram shows a pyramid of the injury prevention efforts based on this upstream-downstream approach. And the green and yellow bands target injury prior to its occurrence. That's the upstream model, addressing the associated risk factors that can be activity-specific, such as in the yellow band, or social and economic factors, such as in the green band. Ideally, we're working in the green band to prevent injuries from happening in the first place and to prevent the risk factors that contribute to injury. And you can see as we move up, we have some examples of our injury prevention programs. So the first one is PARTY, which is Prevent Alcohol and Risk-Related Trauma in Youth. That is a primary prevention program, and that targets specific risk factors for adolescents related to alcohol and substance use behaviors and habits. A secondary prevention example is our new program called Stop the Bleed. And in that program, we teach members of the public how to respond to mass bleeding events. So in this next model, we look at injury interventions that target different levels from individuals to their community and the broader society. Our iNavigate intervention is designed to message safe practices for pedestrians and motorists at an individual level, while our Play Safe program provides a platform for community organizations to track injuries in sport and recreation activities at an organization level, at a community level. Injury preventionists use self-priming frameworks such as this one to guide our work. The first step is to understand the extent of the injury problem, including how much and how bad. The second step includes understanding the causes and contributing factors associated with injury. Third is looking at preventive measures or interventions. And finally, the last step is to evaluate the effectiveness of the intervention by starting the process all over again. And with those pieces in mind, when we know the extent of the injury problem and can identify the causal and contributing factors, we can prevent injuries from occurring. Because of this understanding, we don't like to use the word accident to describe injury events. Because of this, our primary goal is to eliminate traumatic injuries, including concussion. And so we've pulled some headlines that you've probably seen recently in the news, online, in newspapers. There's been tremendous growth in the understanding of concussion injuries, and we've moved away from the idea that knocks to the head are no big deal, or that in sport you have to tough it out for the team, to a place where we know that concussion can be a life-altering injury. But we still don't have a good way to manage the information shared by the media. And so much of it, and the headlines, are alarming without sharing useful information about prevention, management, and more. And we need to cut through the clutter and frame concussion prevention in a way that is responsive to the needs of all people at risk for concussion, not just athletes. And unlike the esteemed panel tonight, I am no medical expert, but I think the leading risk factor for concussion is in fact having a brain. And since we all have one, we need to understand the risks and develop strategies to mitigate. Personally or professionally, when I'm feeling overwhelmed by media reports, I want to know the data. So let's take a quick look at some of that. The leading causes of concussion in Ontario are falls, motor vehicle collisions, and sport and recreation activities. It's important to note that different populations are at different risk in each of these categories. For instance, sport and recreation activities are the leading cause of concussion in younger people aged 15 years and younger, because those are the people who are participating mostly in those activities. Whereas falls is a leading cause of concussion in our older population. In these three categories, the cause of concussion is the contact of the body or the head with another moving or stagnant object. And we can't prevent the brain from moving in the skull, but the question is, can we prevent the originating cause? So likewise, falls is the leading cause of admission in trauma at Sunnybrook at just over 25% of all causes. And our concern is of the older age of these patients and the complex nature of their care needs. And when we look at the national level, falls is the leading cause of death, hospitalization, permanent, partial, and total disability in Canada. The cost of falls alone is $6.7 billion each year. I may sound like a broken record at this point, but we need to address the upstream causes of concussion and falls long before older adulthood. We work with community partners to raise awareness of the impact of falls and concussion and drive upstream programming to address these risk factors. A leading risk factors for falls is physical inactivity and the reduction of strength, flexibility, agility, and balance. In this postcard, the message is that fall prevention begins much earlier than older adulthood. When children have the knowledge, motivation, confidence, and physical competence to engage in physical activity for life, they can reduce the risk of falling when they are older adults. This is concussion prevention. Without saying this is concussion prevention, because at the same time, it's also hip fracture prevention and social isolation prevention and so much more. When we work in the upstream space, remembering that green band in that one diagram, we can address more injury and illness risk factors. Continuing to work in the green band, we're using concepts like physical literacy, defined here on this slide, to promote a better understanding of the connections between physical activity and risk factors for falls. We're using this concept, among others, to study the possible predictors of physical activity in different populations, including knee replacement patients and older adults in community recreation. This is concussion prevention, as well as arthritis prevention and cancer prevention, and so much more. Looking more closely at physical literacy as it compares to other literacies, including reading, math, and music, we are beginning to learn more about the fundamental movements, sequences, and tasks necessary to excel in sport performance, as well as perform activities of daily living across the lifespan. And the more movements included in your repertoire, the more competency you have in various environments. And when you consider the winter we've just experienced in Toronto, and I pray that it's now finally over, the amount of snow and ice we encountered every day, it's even more important that we understand the role of physical literacy in maintaining safety and when we're moving about in our hostile winter conditions. Now, I wish I could stand here and tell you there's a simple concussion prevention strategy, but we know that helmets, while great for preventing skull fractures, do not prevent concussions. And we don't wear helmets when we're walking or driving or carrying on our activities of daily living. So that's just a non-starter. We know that concussion occurs in a variety of environments where people fall, collide, in a way that causes the brain to shift in the skull. So while we're not able to prevent the brain from moving, we have to address those causal and contributing factors associated with the concussion event. In this regard, we're just on the starting line. We have a long way to go to understanding the incidence and severity of concussion, the causal and contributing factors, and the interventions that work best, then documenting them and sharing so that others are able to replicate them. There's no simple solution for getting to the finish line where we can say that we've solved the concussion problem. And that requires it requires a great deal of investment, time, and resources. Since 2013 and the devastating loss of a young 17-year-old girl, we have made strong commitments to reducing the likelihood of concussion and improving the outcome of people with this injury, of reporting and managing symptoms and normalizing the recovery of concussion within the context of school, sports, and work. We've come a long way to harmonize education and policies across the country. And Canada is doing tremendous work to gather passionate researchers dedicated to solving some of the bigger mysteries of this injury for all the people, young, old, injured at play, at home, on the road, at work. Yet we still have such a long way to go. In summary, please consider that prevention is a practice across a wide spectrum of time and population level. It requires understanding of many things, including causal and contributing factors, such as physical inactivity and falls. This better understanding across the top categories of concussion will facilitate reductions in injuries. Again, there's no easy fixed solution. But together we can work towards meaningful interventions that reduce the frequency and severity of concussion, contribute to better diagnosis and management, and return people to play, school, and work sooner than before. And with that, thank you for your time.
Thank you. Thank you very much. That was really interesting. So I'm going to now do the rapid fire Q&A. And for those of you that still have some additional questions, feel free to write them down. We'll bring it to the front. And it's going to be rapid fire. I'm going to try to move things forward really quickly so that we're going to be finished about 20 minutes after. And our speakers may stay around for a few more minutes afterwards if you want to still approach them with one or two more questions. So I'm going to start off actually with Randy. Your last comment actually piqued my interest. You said something about helmets. Is there any evidence right now for certain sports that you should wear helmets for those sports? And do those helmets do anything for concussions, or is it really just reducing fractures of the skull?
Yes.
Turn on your, yeah, that should be fine.
It is on. Okay. Yes. As far as I know, there's no evidence that concussions will be prevented by wearing helmets, regardless of the manufacturer's description of their helmets. But of course, there is great evidence about reducing the risk of fractures, other brain injuries associated with sports, and in many cases, it's simply a rule of the sport organization that you have to wear those helmets. So compliance requires you to wear them.
Okay, thank you. Okay, so I'm going to go quickly. We have access to the slideshow presented by Elkie McClellan. The answer is yes. We'll have those posted. Based on the parachute phases of recovery, taking into consideration that each situation is unique, what would be the average amount of time between the time a person experiences the symptoms from a concussion and the time that they are actually ready to return back to work full time? So again, that's a hard question to answer based on the fact that it's individualized, but I wonder if either Elkie or Dr. Feinstein could give a sense as to what they see clinically on a sort of common things are common. What's the average amount of time that you've seen in your long experience?
Well, I think Dr. Zaretsky more or less answered the question. Everybody is different. Everybody's jobs are different. So some jobs will have more demanding tasks, right? And it really just depends on the person. I think everybody will progress through the stages quite differently. I don't think I can put a time frame on it. I mean, we know that most people after concussion are going to recover. They're going to recover at different rates. So I'm
going to push you on this. 1 year, 3 months, 6 months, 2 years?
So when you look at the duration of post-traumatic amnesia, if you base it on your time memory takes to recover, mild injury, 3 to 6 months, moderate 6 to 12, severe, you don't know.
So there is always, as mentioned by both Elkie and Dr. Feinstein, there is a subgroup of about 15% of individuals that take a lot longer to recover, and that's important to recognize. So here's a question, a controversial question. If the majority of people with mild traumatic brain injury get better on their own, why is the cost that has been incurred in treatment so significant?
Because the numbers of patients are so big. So you're dealing with huge numbers of patients. tens of thousands of patients. So if you look at the 20% of those people not getting better, you've got a very high morbidity rate to this.
So here's another related question. In many motor vehicle accidents, the driver or passenger will often claim that they had a concussion, but this claim doesn't often come about until they start a lawsuit. Since CT scans often don't take place or do not show anything, sometimes the passenger driver doesn't go to the hospital or seek treatment right away. How do you know if they truly had a concussion and still have post-concussive syndrome? In other words, is this valid or an invalid claim?
Excellent question. If you've lost consciousness, you've had a head injury. As simple as that. If you have an alteration in consciousness, that's a difference. In other words, if your consciousness is disturbed to some degree, the American Academy of Neurorehabilitation says that's still qualified for a head injury. So basically it boils down to loss of consciousness or alteration in consciousness.
So the next question is, what causes dizziness after a traumatic brain injury or concussion? Maybe LP or Dr. Feinstein. What causes dizziness?
Oh, there can be so many causes for dizziness. You may disturb the bones in the middle ear. You can have, that's probably one of the commonest reasons for your dizziness is going to be any middle ear disturbance giving you dizziness. You may have dizziness as a consequence of side effects of medication. Those are probably going to be the two big ones. And yes, and the other one Dr. just points out, anxious people can feel dizzy. So anxious people will have their symptoms magnified by their anxiety.
What is the most up-to-date brain scan available that may be able to picture microscopic damage?
So if you have a brain injury, the CAT scan, the scan that you want to do the first 24 to 48 hours is going to be a CAT scan. Because you will see blood on a CAT scan that you might miss from an MRI early on. Down the road, in other words, after a couple of days or weeks, an MRI is far more sensitive than a CAT scan. An MRI can show you the kinds of microhemorrhages that you will not see on a CAT scan. So we ask for an MRI after a couple of weeks or months.
Okay. What percentage of people that suffer from a mild traumatic brain injury or concussion have their brain function return back to normal?
The answer is, over 80%, maybe 85%. One of the big challenges is how do people define normal? And we could have a whole long discussion about that.
How often are brain injuries, even mild, accompanied by spinal injuries?
That's an excellent question. I don't know the actual figure. I can just tell you what we see in our clinic. Our clinic is a very busy TBI clinic, and we see predominantly head injury without spinal cord injury. So although the brain is of course connected to the spinal cord, the traumatic brain injury is not synonymous with the spinal cord injury.
Question maybe to LP. Any specific recommendations for food or vitamins to help with recovery? Any specific recommendations?
Well, I'm not a nutritionist, so I can't really make a detailed comment, but I think if you Google, I know Dr. Google is not good, but you have to be mindful and cautious of that because a lot of people will claim that certain vitamins and nutrients and minerals are going to be helpful for concussion, but don't think that the evidence is that strong. Do you agree, Dr. Feinstein? Yeah. I mean, they talk about magnesium and complex B vitamins, and I don't think there's any harm, is there? But I'm not sure that the evidence really is strong enough.
Similarly, acupuncture with healing for concussions, is there any evidence that you're aware of?
I'm not familiar with the acupuncture literature. I don't dismiss it, I'm just not familiar.
So one of the questions was, I pushed through and did not do the brain rest that you described, the graded approach. What was the impact on my brain of doing that? Did I create permanent damage in going through that process? presuming that they still recover.
Yeah. I mean, I think, of course, it happens, and I think what I always tell people is don't dwell on the past, think of the changes that you can make now. I don't think that you can get permanent brain damage from pushing through. I think what happens is it can just make things a little bit harder for you, maybe a little bit more uncomfortable, and it can take a little bit longer to get better. But again, focus on today and tomorrow, and don't dwell on the past, because that can be very anxiety provoking and make it worse.
So this is a question about a dementia process, and is it possible that something like frontotemporal dementia starting at age 75 could be caused by the person having had concussions in high school or university, possibly while playing football, etc. So the idea of the relationship between concussion and traumatic brain injury and things like a dementing process like Alzheimer's, or we all know about obviously post-traumatic encephalopathy.
So the big issue, as Dr. Tedeschi said, is chronic preventive encephalopathy, CPE, which has been reported in a number of high-profile athletes, etc. And that's a very hot topic now in medicine. These are individuals who had repeated concussions over the years, which many years later can lead to a degenerative brain process associated with significant behavioral change, marked cognitive impairment, and a dementia. It's a very real issue. There are study groups trying to define what the criteria are. As of yet, there's no clear clinical diagnosis for chronic preventive encephalopathy. It's a diagnosis that's made in post-mortem, unfortunately, but it's recognized as a potentially significant issue because the outcome is so poor. And it's one of these hot topics in behavioral medicine right now.
So here's a controversial topic related to this again. Why are sports like boxing and wrestling allowed? And how do we change society's attraction to these sports? Do you personally think we should abolish these sports? I'm going to ask all three people on the panel to answer that question. Starting with Brandy.
Oh, sure. So we work with a number of combative sports, and they're recognized by the ministry. They're funded sport, and I think it's important to consider the full context of the engagement in those activities, who they serve, the benefits that the participants derive from those activities, and the true rate of injury that occurs within those sports. So not everybody is injured when they participate in those sports. Not everybody is injured severely when they are injured. So we work with some combative sports who have tracked their injuries, and they have found that many of their injuries are wrist and hand injuries, not necessarily concussion or head injuries. And so there may be some misconceptions about the rate of injury, the true rate of injury in some of those sports. And although we see at the professional level and high performance level very graphic portrayals of these activities at the younger age groups, I think we need to recognize that there are tremendous benefits for the participation in physical activity, the teamwork, the camaraderie, the social aspect of participation. So it's a bigger question than just should some of these sports be banned outright.
Any thoughts from Elke or Dr. Feinstein about that? Your personal experience?
I think that as Randy was mentioning about Bowen's Law, if I'm not mistaken, I think one of the mandates of Bowen's Law is to teach children from a very young age how to play safely the sport, right? So with football and how to tackle properly and so forth. Am I right?
There's a lot of effort underway to reduce the risk of injury in contact and combative sports. And so again, we can emphasize the positive aspects of those activities and do the due diligence required to make these activities as safe as possible.
My quick answer is I'm not in favor of government's banning things.
Okay. Is there a set standard for assessing concussion in the emergency? For example, balance, walking, CT scan of the head was already mentioned, eye movements, etc. What should all emergency physicians typically do, sort of if they were doing this standard set of assessments for concussion?
Yes, so I spoke a bit about the Glasgow Coma Scale score, which is widely used. It's a very quick measure of head injury severity. There's some really nice work looking at cognition. How is your memory affected? Some lovely work that came out of April a few years back showing that if individuals could remember 3 simple words following a traumatic brain injury, it had a good prognostic sign. So I think focus on cognition, do a Glasgow Coma Scale score, you've covered your base.
Okay, 5 more minutes. I was told that Sunnybrook does not accept patients over 65 in the rehab clinic, but Dr. Feinstein's presentation mentioned the fact that people over 65 also have concussions, and that was also mentioned in terms of falls as being a major factor. So do you want to comment on that?
We certainly do accept people over 65, absolutely. Yeah.
Okay. This is a question for Elke. I have a Kobo e-reader with backlight. I need to read before I go to sleep. I usually don't last more than 10 to 12 minutes. The light turns itself off within a minute or two. Your opinion? Thank you.
Does your reader have a blue light, like backlight? Who asked the question? But I think that that's important because some of them do, and I know that you can buy filters. Oh, the backlight. Okay. So
Just
I'm not
white.
sure. It's just white.
Yeah.
So are you asking if it's okay?
Is it good or bad for getting?
If so, there's no blue light. It should be okay. Yeah.
Okay. Why does it take longer for children to recover? And does it get better as the child gets older? That's about why it takes from a traumatic brain injury. Why does it take longer for children?
I don't think they really know the answer to that. I think the children's brains are different. They're still maturing. And I also think that children have different demands than adults as well, and maybe more pressure maybe with school. I don't think they really have a good answer for that. Do you know Dr. Feinstein? No.
I think a developing brain can be a very sensitive brain.
Okay. There's one question about Sidney Crosby, who had a serious concussion and sought opinions from different centers, and apparently had an unusual treatment with some machine that moved him around very vigorously. Seemed very extreme. Does anyone know about that? And any comments about any unusual kinds of rehab that is done for people with concussion?
I do not know of any machine that should move you vigorously after a concussion, but Elke did mention Sidney Crosby the other day in our clinic.
I'm not familiar with the specific procedure that Sidney Crosby had, but I think what's really important to keep in mind is that when you are seeking treatment, I mean, some are going to work and some aren't, but I think that the main message is that you want to choose something that's evidence-based, and that's why it's so important that you take a look at the guidelines, pick up one of those books that are outside, and it will guide you a little bit in terms of how to find concussion care that is evidence-based. You have to be careful with clinics that are going to be advertising a really quick fix for concussion, because there really isn't one. And some of these procedures can be really expensive and costly. So you just have to be mindful and be very informed before you decide to go ahead with a procedure.
So that's the conclusion of our Q&A. I want to thank all of our incredible speakers for the great presentations. Our panel will have a few minutes at the end to take maybe 1 or 2 questions. And recognizing the importance of learning from our patients, we want to remind you about our weekly Sunnybrook blog called The Personal Health Navigator, written by Paul Taylor. It's at askpaul@sunnybrook.ca. Special thanks to our speakers and those exhibiting outside the McLaughlin Auditorium. Can we give our speakers a hand? Please be sure to fill out your evaluations about this evening, because we really like your feedback, and also pick up a free parking voucher. Visit the Sunnybrook website at www.sunnybrook.ca for updates, and thank you once again for joining us. Safe travels.